So now the next order of business is our CE class. And this evening, we have Dr. Peter Kawamura. He's going to be talking about geriatric dentistry and teledentistry. So just a little bio about Dr. Kawamura. He is a graduate of UCSF, a class of 1982. He did a GPR in Honolulu and practiced there until 1989. He then completed a geriatric dental fellowship in Milwaukee and took a position with the Department of Veterans Affairs Medical Center in San Francisco, the VA in San Francisco, where he was a GPR director for 8 years and coordinated oral care for the 120-bed nursing home care unit on campus. For the past 20 years, he has developed and maintained a small part-time portable dental practice with a mission of providing dental access for homebound elderly patients. And he completed his prosthodontic residency at UCSF 2004 and continued to work at the VA until 2016 and retired 2017. He has been the director of the Oral Health Strategic Plan for San Mateo County. He is now semi-retired, works 1 day a week at Ravenwood Family Dental Clinic at East Palo Alto, and maintains a very small part-time portable dental practice. Ladies and gentlemen, thank you. I'd like to welcome and thank Dr. Kawamura for this evening's presentation. Dr. Kawamura, thank you, and you can take it away.
Okay, thank you, Dr. Bexer. Thank you for everyone for having me join you this evening on this installation evening. Well, thank you again so much for inviting me to speak with you folks. Tonight's topic will be on managing the geriatric dental patients, strategies for treatment. As Dr. Yang mentioned, I'm semi-retired and much of my week is spent taking care of our 2 grandbabies. So it kind of seems like a full-time job, you know, but it's very enjoyable. So I can't knock it. So before we start, I want to really quickly talk about some of the things that are happening in the world of organized dentistry in regards to geriatrics. The ADA and the FDI World Dental Federation recently put together a document called Oral Health for an Aging Population. It's a series of guidelines intended to help dentists manage older patients. And one of them is a chairside guide. If you want to, you can take a picture of the website there. And it's very comprehensive guideline that can be used to help understand the flow of managing care for the older patient. The document kind of groups the patients into categories of general health condition, whether they're robust or frail or dependent, and the levels of dependence that they have, whether it's none or low or high levels of dependence. And then these are cross-matched with the domains of care that are needed to manage these patients: the assessment, prevention, treatment, health promotion, and education. These guidelines are based on the Lucerne Care Pathway and a comprehensive Canadian study of health and aging. It's a very robust guideline, and the focus is on assessment, prevention, and health promotion and education. And it provides the practitioner with a broad overview of how to intake patients, how to assess them, and how to manage their care. On the home front, also, the question is, will geriatric dentistry be a new ADA recognized specialty? In July of 2019, the ADA Council on Dental Education completed a feasibility study that looked at the possibility of having another recognized specialty in dentistry called geriatric dentistry. The House of Delegates passed Resolution 69H, which requested the Special Care in Dentistry Association, the SCDA, to look at this feasibility study and to make recommendations. And in the early part of this year, I think it was either January or February, the SCDA completed their report and returned it back to the ADA with very, very favorable recommendations. So at the organized dentistry level, there's growing interest in advanced dental training in geriatric dentistry. For my part and your part, at least for the near future, for the next few years, we are going to be continuing to see patients, more and more patients as our population ages. And they're going to be a complex mix of issues. My patients typically are this kinds of patients with a lot of things happening with them. These issues are easily made unstable and oftentimes resistant to change. They oftentimes have decimated dentition, multiple medical problems, multiple medications, mental status issues, oftentimes functional issues, and issues regarding families and caregivers. So when I've been thinking about how my practice has evolved over the years, I realized that my dental practice, my success in treatments was basically procedure driven. When I make a good crown, a beautiful crown, that's a dental success, and that makes the patient happy. When I restore the dentition with crown and bridge and dentures and everything comes together, that's a dental success because these are all procedure-driven activities. So it wasn't unusual for me to take a patient. We have had, say, a class 3 occlusion with old partial, and then redo the partial, redoing a fixed unit, fixed partial denture, and remaking mandibular partial denture, and creating a dental success. These are all procedure-driven activities. And I realized that, my dental successes resulted in patient successes because the patient basically was treatment tolerant. They allowed me to work on them to get things done. But as patients age, we come up against a lot of issues that are much harder to deal with. Take for instance, a patient who has multiple missing teeth and roots, loss of posterior support, may have cognitive issues or functional issues that make it difficult for them to participate in treatment. Or a patient who has teeth, but very few of them actually come together. And the teeth that they do have are so broken down and decimated that you may be wondering whether it's worth it to even keep these teeth. And on top of that, the hygiene may be so bad that you kind of know that anything you do will result in failure sooner than later. Or a patient who has, again, teeth, but they're all in the wrong place, basically, with none of them touching, but they come with so many cognitive and functional issues that that whatever you did would probably end up with a worse situation than restoratively than if you did nothing at all. So these dental successes that we're so used to having, oftentimes in the older patient, result in patient failures because the patient is intolerant to the treatment or the prosthesis. So it makes it much more difficult to deal with situations like this. So I found that for me, in order to provide care, I've had to kind of force myself to go through this paradigm shift in thinking about how to provide care, how to plan care, the sequencing of care. And this paradigm shift kind of goes like this. The patient comes in and you kind of attend to their, what we call global issues, which we will talk about in a bit. We focus on more of the dental issues and the procedure strategies. to manage those issues. That leads to dental success, for instance, the perfect crowns, perfect dentures, the perfect implant, restorations, and that results in a patient success. In my paradigm shift, what I've had to do was to place patient success at the top of planning. So that becomes a focus of my work. So a patient comes in and we deal with the global issues and we develop management strategies to deal with these global issues. And then we kind of use our procedure strategies, our clinical skill sets that we have to manage the dentition and to meet our goals of treatment. And together, by addressing the global issues and the dental issues, we create what I consider a dental success for the patient, and that in turn results in a patient success. For instance, the patient's able to tolerate, uh, partial denture or complete denture that they may not have had before. So when I look at patient successes, I think of these kind of things as my goals. I want to minimize and eliminate all pathologies. I want to minimize or control periodontal infections. I want to control or eliminate dental infections first. And then I can stand back and I can say, well, how do I want to maintain or improve their function? And how can I improve the aesthetics if possible? I also want them to be able to tolerate the treatment. A lot of my patients have issues that make it difficult for them to sit in the chair or even get in the chair. I need them to be able to cooperate during treatment and comply with after treatment regimes. So it makes it a lot harder to deal with patients if they're not working with you as you're providing the care. I need them to be able to use and care for the restorations and prostheses that I make for them. And I need cooperation and effective participation of caregivers. Oftentimes, this is probably sometimes the hardest part to deal with when managing the kind of patients I work with. So patient success depends on addressing these global issues, these dental issues, so that I can create my dental successes. So let's take a look briefly at some of what I consider these global issues. These global issues I consider to be the non-dental issues, things like medical history, allergies, medications, vital signs, patient interest, and financial limitations. In particular, I want to focus a couple of seconds on functional health. In geriatrics, we talk about functional health. We know that we're never going to cure the patient, or the patient will never be cured of their multiple, comorbidities. So what we want to look for is how well controlled they are. Are their diseases well compensated for? Are they on the medications that they need to be taking? Are they not having exacerbations of their, problems? Have they been pretty stable? Do they have enough physiological reserve so that they're able to tolerate the treatments, and just how functionally healthy they are. So this is what we look for. Can't know all the diseases, all the treatments, all the medications, but we have to know enough so that as we review their medical histories, that the red flags of problems will be able to come up, and so that we can zero in and focus in on these issues so that we can provide safe care. In addition to these things that we all do as practitioners in geriatrics, we're also focusing on mental status issues, functional issues, and caregiver issues. So why mental status issues? Well, basically, the patient is the source of the historical information. There's a lot of research available that shows that patients are poor historians. Plus, they only tell us what they think we need to know to treat their problem. They won't talk about the pain in their thigh that they're having that's continually getting worse by the hour, because it has nothing to do with the toothache that they have, or at least they feel that it doesn't. So We need to be able to tease out information about their overall general health and learn about that, increasing thigh pain, because that could be a sign of a deep vein thrombosis that could be lead to, pulmonary embolism, and, serious medical issues. Yeah, we need to understand how they're able, how competent they are so that they can give us informed consent, and whether they have the capacity, the mental capacity to do that, which we'll talk about in a second. Um, we need their cooperation during treatment, and we need their cooperation after treatment, with, the follow-through care. So mental status is important for us to understand in order for the patient to participate in treatment. What are the components of mental status evaluations? These are examples of what we kind of look for, and it sounds like a long list of things, but kind of think about it. When we meet each other for the first time, we're always looking to see how alert the person is, whether they're oriented to, what's going on, whether they're paying attention to us, how cooperative they are, whether they can follow directions when we're talking to them, what kind of memory they might have, and what their overall judgment and insight into things are, just so that we kind of get a feel of where we are relative to that person. So how do we look at alertness? Well, alertness basically is how awake the patient is, whether they're awake or alert or sleepy or somnolent. We also look at orientation. And orientation is a broad indication of patient's overall cognitive functioning. We kind of try to get a feel for if the patient knows who they are, where they are, what time of day or where they, what time of season it is, and why they're there with us. That we'll call situation or purpose. When patients have problems understanding the situation, we know that they have some higher level executive functioning problems. Patients can often get a feel for where they are and the time of day based on environmental cues. And when patient starts to not respond to who they are, we know that they have very serious cognitive problems. Other issues we look at are attention. Can the patient remain focused? Patient can't remain focused. It's very difficult to deliver care. How cooperative is the patient? Dentistry is one of those few healthcare services where we're actually providing care to the patient, and the patient is basically allowing us to hurt them. So, we need them to cooperate so that we can get them to a point where they're not feeling pain or discomfort so that we can deliver our care. Is the patient able to follow directions? Patient, needs to be able to participate in treatment and understand what we're asking on them. Oftentimes, patients who have, say, receptive aphasia, they cannot understand what we're talking about. So it's difficult for them to respond in an appropriate manner because they're not receiving the information. The part of the brain that is needed that interprets the incoming information has been damaged, so they cannot respond appropriately. We always look at patients' memories, and that memory basically is the ability to retrieve information from the past. And there are two types of memories: remote, things happen in the distant past, and recent, things that you remember that happened a few minutes ago, a few hours ago, a few days ago. Most of my patients can't remember who I am 5 minutes after I talk to them, which, I guess it could be good in some sense, settings, but basically I kind of want them to know who I am because, I'm working on them. And of course, judgment and insight, And basically, judgment and insight relates to understanding what the situation is, where they're at, and making informed or appropriate decisions. So here's kind of a wordy slide, and I kind of want to spend a couple minutes on this. This is kind of like my mini class on dental ethics, and it's a statement on mental capacity. And mental capacity is what we're looking for in the patient so that they can give informed consent. So mental capacity is a functional term that can be defined as the mental or cognitive ability to understand the nature and effects of one's acts. The term capacity is frequently mistaken for competency. Capacity is determined by a physician and not the judiciary. So, in other words, competency is a legal term that is used to describe whether the patient has ability to make decisions, whereas capacity is a functional term based on clinical findings and observations and evaluation. Capacity refers to an assessment of the individual's psychological abilities to form rational decisions, specifically the individual's ability to understand, appreciate, and manipulate information and form rational decisions. So, as you're talking to your patients, what you're doing as a provider in an informal way is determining the patient's capacity to give informed consent. You're not trying to figure out whether the patient's competent. You're trying to determine whether the patient has the ability functionally to provide informed consent based on the information and about the risks, benefits, and alternatives of treatment. Okay, let's move on to functional issues. Most of our patients, they come and go, right? They have an appointment, they come, they finish with the appointment, they go. With the geriatric patient, it's oftentimes much more difficult for patients to come and go. And over the years, I've realized that there are at least 10 reasons why functional issues are important in my practice. So number 10, the patient needs to get into my office and transfer into and out of my chair. So, I've always been told that if the patient can drive to your office, get out of their car seat, get up the elevator, and get into your office, then they're able to sit for you. In fact, at least in Hawaii, there was a time when dentists always had their office on the second or third floor. This was before they had elevators. And so the rationale behind that was that if they were able to walk up those flights of stairs to get to your office, then they were functional enough or healthy enough to sit in your chair and get work done. Reason number 9, patient needs to position their head or their body or mouth for easy oral access. We kind of take it for granted that we're working on the patient and our chairs have articulating headrests and we can kind of position the patient the way we want. But as patients get older, oftentimes there's spinal deformations that prevent them from positioning their heads appropriately and safely. Sometimes there are issues with spinal stenosis, especially in the cervical upper thoracic areas, which minimizes the range of movement that the patient has. So you have to be really careful about assessing whether the patient can get their head in the right position for you to provide care. A patient needs to be able to remain in position without moving. Goes without saying, but with today's older population, a lot of patients come to your practice who have movement disorders such as Parkinson's disease. There are special needs patients who have movement disorders. There are patients who've been on certain kinds of psychoactive medications that have caused tardive dyskinesia. And these involuntary movements oftentimes make it really tough to provide care. I often tell residents that they have to do kind of like what I call Tai Chi dentistry, where the patient moves, you move with them. You kind of have like everything's real sticky hands, so you're kind of, they move up, you move up, they move down, you move down. And after a while, you kind of learn to run your handpiece moving with them. So it's almost like a dance that you're doing to get the work done. And then you find opportunities where they stop, and then you go go go, and then they'll start to move, and then you stop and you pull back. So it's almost like a dance with them that you have to feel comfortable doing. Okay. Number 7, patient needs to be able to insert, remove, and maintain prostheses. Obviously, but we make these prostheses and we don't even think twice about, oftentimes, can the patient get it in? Can they get it out? How are they going to keep it clean? We often delegate those responsibilities to somebody else. And in fact, I kind of do that at work. And I kind of realize that oftentimes with my patients, I need to spend time talking about these things. Recently, I had an elderly, developmentally disabled special needs patient I made dentures for, and I needed to spend the time with the family and with the patient to discuss how to take care of the denture, so that so that I could feel comfortable that they're able to maintain and use the prosthesis. Number 6, patient needs to tolerate and use the prosthesis. Yeah, so I had a patient once who made a denture for partial, and he had a left-sided stroke with right-sided paralysis and some paresthesia in his face. And he came for follow-up visit, and he said, "Doc, I can't wear my denture." So I told him to put it on. And when he put it on, the eye bar of the denture went over his lip. And when he put it in, his lip got caught between the eye bar and the teeth. And so it got pinched. And he said, "See, I can't I can't put it on." And he couldn't feel that he was pinching himself because he didn't have the sensation in his lip. So they're not able to tolerate or use the prosthesis because they don't have the sensory input. So I had to go over, having used the prosthesis, put it in and out, using visual cues, looking at a mirror so that he knew what he was doing. Reason number 5, a patient needs to perform effective oral hygiene. Uh, it goes without saying, whatever we do for the patient, they can undo in a matter of months. We can spend 20 hours working on their teeth, but in 3 or 5, 6 months, they can undo everything if they don't have effective oral care. So it's really important that the patient participates in the care of their own mouth so that they can preserve their dentition. You need to know reason number 4, you need to know whether you need to give caregivers instruction. So oftentimes dealing with caregivers is the hardest thing to do with because they often feel like you're the one providing the care, and they'll come in, bring their mother in, and zoom, they're out the door. So they don't want to have anything to do with it because they got so many other things to do, and they're so burnt out that they don't want to have to deal with this. So you have to know when to instruct the caregivers and work with them. Reason number 3, patient needs to have a patent protected airway free of debris when you're seeing the patients. A lot of older patients have silent aspiration. Rate of silent aspiration increases over the age of 65. And when you think about providing dentistry, we're basically providing care with things in the mouth that are loose and moving around, and we're working in basically an open tube that has access to the throat and the stomach. So we need to protect that open tube and block it. Um, we often say, "Oh yeah, you need a drape of some sort." We call it a throat pack. I don't like to use the word throat pack because a throat pack, you really pack the throat, like in the operating room. But I like to call it oral fringe or drape because it covers the back part of the mouth and it helps to capture stuff. Personally, I can tell you there's no worse feeling than not being able to find your cover screw or your implant screw because it popped out and dropped into the oropharynx. it gets like it just makes all the sweat pores in your forehead pop open. And a lot of this could be prevented just by having an oropharyngeal drape in the in the ready. Reason number two, you don't want the patient to be incontinent in your chair. Yeah, yuck. These patients oftentimes won't tell you that they need to use the restroom because it's so busy trying to get to your office, and when they want to be on time, and they, you know, their bladder will be excited and everything, the bowels will be excited, and you have to be able to stop and determine whether they need to use the restroom before you start treatment. Because when they need to go and they're in your chair, it's not like they can just stand up and go. You know, they have to stand up and go. Okay, so you know by that time they've already gone. So you know it could be a very frustrating day when you do that. So be sure that you know you have the patient toilet themselves, use the restroom, get comfortable before you know you see them. And the number one reason for understanding the patient's functional abilities is you don't want the patient to fall. Falls are probably the number one cause of death in the elderly because they lead to immobility, fractures, pneumonia, and all the other comorbidities that and consequences that come with immobility of the elderly patient. So you want to be able to get them up safely, give them time for the blood pressure to equalize and the circulation to equalize and neurologically, you know, orient themselves to space and position so that they can safely navigate the halls of your office. Okay, so identifying functional issues. We normally look at ambulation and mobility, whether the patient is able to stand and walk and how mobile they are. Are they shuffling their feet? Because if they are, which a lot of older people do, they have a much greater tendency of falling. Are they wearing slippers? Like everybody does in Hawaii, everybody wears slippers. Much more common for them to trip over them. Can they transfer? You know, can they get out of a chair into your dental chair, out of a wheelchair into your dental chair? Are they able to bear their own weight? I always tell practitioners, if the patient cannot bear their own weight, you should not be trying to transfer the patient. Neither the dentist, you or your staff have the training, the strength, the conditioning, or the coordination as a team to do this safely on a regular basis. My niece, who's a physical therapist, routinely strains her back, uh, working on her patients, trying to transfer them, and she's trained in doing this. You know, it's a very difficult process. So if the patient's not able to bear their own weight, you really should not be attempting to be a good person about it and try to transfer for them. Um, Weakness or paralysis. Does the patient have a strong side? When patients have strokes, they generally have a weaker side. If they have a weak side on the right, they should never be moving to the right. They should always be moving in the opposite direction on the strong side. It's a little bit difficult to describe, uh, and it would require you to kind of sit in on learn how to safely transfer patients. But if the patient does have a weak side, never move the patient to their weak side because it's you're asking them to basically fall into a space. Are they continent of bowel and bladder, which you talked about, and when was the last time you used the toilet? There are other ways clinically that in geriatrics and in medicine we look at how functional a patient is. We call these activities of daily living. I'm sure you've heard of these. And we look at how continent the person is, where of bowel and bladder, whether they can do their own hygiene, bathing, oral care, and things, whether they can feed themselves, dress themselves, and whether they can have functional movements like ambulating and transferring. For our purposes as dentists, we want to know if they have range of motion. Are they able to reach their mouth to provide oral care? Handedness, are they right-handed or left-handed? Because a patient who's had a stroke, left brain stroke, who's now weak on the right side, is functionally more dysfunctional than a patient who was left-handed prior to the stroke. Okay, so you have to kind of understand where they are functionally after any kind of catastrophic illness to find out what the functional level is. Grip strength. The patients oftentimes don't have the grip strength to hold the toothbrush or the electric toothbrush. So you have to find out what is appropriate for them. We have a test called Grab My Fingers test, pretty descriptive. And you ask them to grab your 3 fingers, the 2 fingers, and your 1 finger, and you kind of assess at what level they can grab your finger best. And that's the size of instrument that they should be using, whether it's a manual toothbrush or electric toothbrush or what have you, to clean, because that's the size that they can control the best. Identifying function issues also includes understanding whether they have a gag reflex, swallowing ability that we talked about, and coughing reflex or ability, because these are the protective functions that the patient has to prevent things from dropping down into the throat as you're working with them. And we want to look at caregiver issues. Sometimes these are the hardest things to deal with. There can be many issues involved, interpersonal dynamics, loss of control or independence, desire to care for versus doing undesirable things. I've had families tell me, oh, I'd rather be cleaning their bottom than brushing their teeth. It's so icky. Yeah, I don't know. I'd rather be cleaning their teeth than cleaning their bottom. It's just, perspective. But, everybody looks at things differently. We know oral care traditionally has a very low priority in care of the patient, whether it's in an acute setting, a long-term care setting, or at home. And oftentimes people feel dental care is a dentist's responsibility, not theirs. It's your responsibility. So, you're the one who needs to, take care of my mom, not me, So in managing caregivers, I think it's important that, you include the caregiver as part of your patient family complex, that the family caregiver and the family member is treated as well, at least managed as well as the patient. You need to get the caregiver or family on your side, because you oftentimes need to have their support and their approval and their assistance in helping to care for the patient. And you want to simplify tasks for the caregiver. Please don't expect the caregiver family to use interdental proxy brushes and then floss the teeth and then rinse the mouth with Paradex and then brush the teeth at a 45-degree angle to the gums and use a semicircular movement. It just won't happen. Okay, they've got so many other things to do that, they just, you need to find the simplest way for them to provide care. So basically, you need to develop caregiver skills. You need to try and have little successes in small areas at a time. And you basically want to empower the caregiver so that they know that they can do it, but more importantly, because they want to do it, and that they know that you're there to help them and when they have a problem. Again, putting patient success at the top in order to get things done for the patient. Okay, let's take a short break, 30 seconds. If there's any questions, no, nothing. I'm looking at Megan.
Not so far, just a thank you for coming out and speaking tonight.
Okay. Well, let's move on, because now we talk about some dental stuffs.
Cool.
Okay, so let's talk a little bit about the dental issues. These are things that we are familiar with, the oral pathologies, the perio, the endo, implant issues now, but also, chewing, swallowing, and speech issues, right? Over the years, I've kind of realized that there are just certain teeth that are more important than others, at least, for my patients. And these are the teeth that I think in my practice are most important. Teeth in occlusion, obviously, at least one tooth on either side of the arch, kind of in the same coronal plane, because if you were to make dentures and having teeth in the same coronal plane allows you to use them as abutments and have favorable rotational paths, rotational axes. Uh, Teeth with periodontal support, teeth with enough tooth structure to restore, maxillary central, lateral incisor. Okay, so this sounds kind of odd, but I once had a request to go to a care home to see a patient who was on hospice care, who was pretty close to actively dying. And the family said that he had a loose upper front tooth and they wanted it to pull out. So I went to see the patient, and he was obviously actively dying already. He was very close to the end. He had a very loose maxillary incisor, I think it was 8 or 9, and it would have been very easy for me to remove. But I asked the family, okay, look, I can remove this tooth, but can you live seeing your father like this for the next few days without his upper front tooth? Because when I take out this tooth, his mid face is going to collapse. He's going to look 1,000 years older and 10 times worse than he is now. And so they discussed it amongst themselves, and they decided not to do it because they were not. It was they're grieving so much already that it would have been harder for them to deal seeing their parent there with their upper lip caved in like that. So in this case, I was working with the family, basically treating the family more than the patient. But it was a strategic tooth because it helped to maintain the person's facial appearance and their sense of dignity. And it was more comforting for the family to deal with than to just go ahead and do the procedure. Okay, cuspids. By cuspids especially because, they're posterior teeth, they provide occlusal stops. The lone standing molar, because the lone standing molar can change a distal extension partial denture into kind of like a tooth-borne partial denture. And then finally roots for occlusal stops, which they can do the same function. So there's teeth in occlusion. These are more bicuspidized occlusion. The patient here basically only has 2 teeth in occlusion, but there's still stops for him. Posterior one tooth on either side, and basically bicuspidized occlusion. A lone standing molar here, even he could have occlusal stop here or occlusal stop here. So he still has occlusal stops. And this lone standing molar, we kind of gussied this up for the patient, cleaned it up so he could have occlusal stop there because it was a lot more difficult for him to sit for, impressions and stuff. So what I found was there's some occlusal schemes that work for me. The one that I like the best is a shortened dental arch. This is where you have anteriors and bicuspids, but you don't necessarily restore or recreate molar occlusion. But you do have posterior support because you have the bicuspids in occlusion. I like to have flat occlusal morphology, just so that it gives the patient some freedom in movement. I want occlusal contacts with forces directed axially through the tooth with no lateral contacts. I try to avoid contacts on tooth inclines because that tends to cause fremitus and tooth mobility. And any cusp tips that are thin because they've had wide MODs or DOs or MOs or whatever. And so the buccolingual cusps are thin. I tend to flatten those cusps so that they're out of occlusion and less prone to fracture. I like flat emergence profiles so that there's no protective contours at the gingiva, so there's less plaque collection. I like the margins of crowns at the height of contour or just subgingivally. I like metal occlusals with hooding because it protects the porcelain. I'm I guess old school pros, so I like full metal crowns on posterior teeth because I feel like they just provide more stable posterior stops in the long run for the patient, and in theory wear more evenly with the natural teeth. And I also look for adequate horizontal overjet so that when the patient functions in their functional envelope of movement, that they're not cheek biting or they're not chewing their lip up. So here's an example of bicuspidized occlusion here with a hooded crown protecting this porcelain here. Yeah. And this is a bicuspidized occlusion here that we'll take a look at in a couple of minutes. I like to manage certain things first. First things first, I like to kind of look at the saliva of the patient, how good the hygiene is. I want to try and deal with any acute infections in the patient's mouth. And of course, if there are any pathologies, I want to do that because the goal is to get the patient stable first and then consider how we want to build up and restore their occlusion. So as a quick review of saliva, I want you to remember that saliva has multiple functions, including preparing the food bolus for swallowing and speech facilitation. Like right now, I'm talking so much, I'm talking too much. So my mouth is dry, my tongue is getting stuck to my teeth and everything. So, saliva is pretty important in lubricating everything and keeping everything running smoothly. So when you look at saliva or lack of, you're looking for that subjective feeling. That is the key, subjective. And you should also look at not just how much they have, but the consistency of it. Because objective signs, of saliva flow problems may not be present because it's more of a subjective feeling for the patient. Sometimes you may not even have frank dryness, or some patients may have some frank dryness and not even complain about oral dryness. But if the patient has kind of a thin, ropey or frothy saliva or viscousy kind of saliva, kind of like what patients have who have head and neck cancer, radiation, you could be pretty sure that the quality of the saliva is not good. And you can expect to see more root caries, and you can expect to see more adherent mouth debris and plaque. So how do we manage saliva? Well, the first thing you have to do is recognize the influence of polymedicine and polypharmacy. Okay, polymedicine, and polypharmacy, they kind of sound the same, but they're really different. Polymedicine refers to multiple medications being used to manage multiple problems. Okay, whereas so if the patient has 5 diagnoses, they may have 5 or 6 medications to deal with it. Polypharmacy, on the other hand, refers to having multiple medications to treat multiple problems, but the medications are causing adverse drug effects and side effects and problems for the patient. So they may have 10 drugs to deal with the same 5 problems, and the physician could modify that or tailor that to the patient so that maybe they'll have 6 or 7 medications to deal so that they don't have as many side effects. Look for saliva characteristics. Always rule out salivary gland pathologies, even if you can't see them, feel for them. Ask about fluid intake types, patterns, and always assess for dehydration. One of the problems of being of the elderly is that they're oftentimes are dehydrated. Some people say that they lose the thirst mechanism, or it becomes blunted as they get older. A lot of people just don't drink water. Like, for instance, I don't drink a whole lot of water. And my wife is always constantly telling me to drink water, drink water. I just don't drink water. I'd rather have coffee. I like coffee. Leave me alone. I drink coffee. But dehydration in the elderly is reported to cause anywhere from 6 to 7% of hospital admissions. So it's a real problem in the elderly. And you as a provider will often see the patient, and you can be the first line or network of caregivers who can assess these things and get the patient into care. My patient last month was dehydrated. She fell, and they had to kind of rehydrate her for a week before I could see her. She just was not drinking enough fluids. Okay, managing saliva. Water is the best, obviously. I mentioned pilocarpine and this Evoxac, only because they're out there. I have not used them. I would not use them because my patients already are on so many medications. I find that just drinking water, having water available, helps to keep them hydrated, uh, helps to keep the mouth moist. It helps to control the amount of debris in the mouth. And of course, other things like chewing gum or sugarless candies. Watch out for those xylitol containing things because it could create diarrhea. But hygiene, fluoride varnish, and silver diamine fluoride also, are going to be very important. So when you talk about managing patient's hygiene, you have to remember that providing oral care in yourself is not the same as doing it on someone else. I gave a class to a group of ICU nurses once because they wanted to learn more about providing care for the patients. All of these nurses had excellent oral health. The no inflammation, no caries, no nothing, no debris. And then when I asked them to do it on their colleague, they were like, they were like lost. They were like, oh, I don't know what I'm going to do. They didn't know what to do. It's like, so it's a different skill set, and you have to be able to train these so that they can demo back what they need to do. You cannot assume that because they brush their teeth that they can brush other people's teeth, because it's just not the same skill sets. Develop skills in small increments and select the most effective cleaning tools. I can tell you that electric toothbrushes may not always be the best. You just have to find whatever works for the patient. I use oftentimes a thing called a benefit toothbrush. It's a 3-headed toothbrush. It cleans the outside, the top, and the inside at the same time. And the model has changed over the years, gone through iterations. And now it's called Easy Dog. It's a toothbrush that is used for animals. I had to get mine from PetSmart, I think it was, but you can also get on Walmart. Originally the brush was designed for patients with disabilities, but the inventor told me that he couldn't sell it. And then one day, a dog owner saw it and he said, I want this for my dogs because I show my dogs and the teeth have to be cleaned. So he started marketing to dogs, and now there you go. It's Easy Dog. Hygiene. Hygiene recalls frequencies may have to change every 6 months, every 3 months, every other month, maybe more effective. Use chemoadjunctive strategies like chlorhexidine, caries-free, which is kind of like I don't want to call it Clorox, but it's very similar type of compound. Fluoride rinses, gels, and trays. And of course, fluoride varnish and SDF. Fluoride varnish has been a mainstay for caries prevention. And I use it liberally with my patients. put all over the root surfaces to protect the roots from the patient, basically. And silver diamine has been basically a godsend for caries management. In the United States, we have what do you call this thing? Advantage Arrest by Elevate. As you know, it was licensed in 2014 by the FDA, and in 2016 it gained gained its D1354 CDT code for use as a caries arresting therapeutic. This is what I use. I carry this everywhere with me. It's like I practically staple it to my forehead so I don't lose it whenever I go out to see a patient. And this is how I use it. I'll put a gauze in the front, a gauze in the inside. And I don't know if you notice this thing here, but this is floss attached to the tube, and the floss runs out of the mouth so that there's no chance of the patient aspirating the floss. Okay, and then I apply the SDF to the root surfaces. And these are kind of soft root surfaces, and they're not cavitated. So I'm going to just treat them with SDF. The Association of State Territorial Dental Directors has a nice fact sheet on SDF that you can download and print. This is the website, but you can just look up ASTDD and look up the SDF info sheet. I treat infections, pathologies. Next, I obviously any oral lesion should be biopsied. I do a lot of scaling and root planing. I've got scalers and root planing tools all over my house, everywhere in my house. I even tried on my dog. I just like to see how these different scalers work. Impossible, hopeless teeth would need extractions. And, I haven't done a root canal on a homebound patient or nursing facility patient in years, but it's something you need to consider versus extracting. For caries and defective restorations, I use SDF on all non-cavitated surfaces, and anything that is cavitated, I do restorations. Basically the goal is to create a cleansable surface, a convex or flat surface that's not concave, and to restore some kind of functional occlusion. So here's one. You can't see it here, but this is this. I had an occlusal contact here. So I went ahead and I built this up with composite, some pins. And the way I designed this was I created areas in the tooth so that as the composite cured, it would shrink into the tooth and grab the tooth more tightly, is what I thought. It's kind of like concept of stacking porcelain, how it shrinks. And this is a case that I did. I'm going to show you how restoratively I worked on it after I did these 2 root canals and after I did the rubber dam. This is a breathing holes. That's what I always call them. But actually, I kind of, that was where the rubber dam was supposed to go. But instead, I sort of say it's breathing holes for the patient. Okay, so a little bit about what I use. And I'm not promoting these products, okay? I use pins. You can use any kind of pins you want. I know pins have gotten a bad rap over the years because people say they fracture teeth. And yes, I've had whole cusps fall off, crack off, but I've been pretty lucky since then. This is the 021 size, and this is the 027 size. They're self-shearing pins. I run them pretty slow, and I think I run them at was less than 30,000 RPM, so closer to 10,000 RPM. It's enough so that it can shear the pin and seat it. And these are my restorative materials. Again, I'm not promoting these or anything, but these are just the types of materials I use. I have some kind of glass ionomer cement, which I can just mix by hand because sometimes I don't have my light curing unit. I like to use Fujifil LC, which is a resin modified glass ionomer. And my go-to for just about everything when I'm filling in a clean environment is flowable composite. I just like the way I can use this tip and I can seal the cable surface margins, and I can build up walls against the matrix band, and I can essentially convert a fill from a class 2 fill to basically a class 1 fill. I like posterior composites because they're all really hard and they're much more wear resistant. And over the past couple of years, I've gotten reattached to amalgam. Amalgam is the only restorative we have in dentistry that will set underwater. And there's no time with my patients, practically no time, when I have a dry environment. So amalgam works well for me. So here I am working on this patient. I put these 2 pins on and I created a well here. So when I put the composite, I could run the composite at the cable surface margin, run it up and into the well so it grips everything together. We've built it up, we carved it down, we put a polish on it, and then shined it up. And there you have it. This one had a little bit of incisor composite, and these also afterwards had the same. Okay, so I know your eyeballs are glassed over, they're red, and you want to get the heck out of here. It's getting late. It's after 8 o'clock, I believe. Is that right? It must be after 8 o'clock. Hallmark Channel movies has already started, and I know you want to get to it. So hang on with me. There's just a few more slides. Please don't forget that there's also atraumatic restorative dental treatment, and we're using just hand instruments. This is a sharpened spoon, Woodson carver, an what do you call this? Hollenbeck, and a Tanner carver. It's a number 6 Tanner carver for carving interproximally to smooth things out. Minimally invasive dentistry, I mention this because it's more of a concept than it is a specific set of skill techniques. It's an approach to care. There are some special burrs like this polymer burr that's supposed to remove only infected dentin and not affected dentin. But the idea is you want to do conservative caries removal. You want to use bioactive materials to promote the remineralization of the tooth structure, or apply fluoride to the surface. Oftentimes there's prep design modification. For instance, a class 3 slot prep for interproximal caries instead of a traditional tooth surface preparation with occlusal isthmus. And then recently I saw this thing about perimeter repairs. I guess it's just like repairing the margins of crowns or fillings that look defective. So you're not taking out stuff and redoing it and creating a bigger hole. Try to maintain or recreate function as soon as possible. Oftentimes patients are on the edge of health. Physiologically, they need to be able to get adequate nutrition. So you don't want to disrupt their ability to eat. Acrylic partials, not flippers, okay, but acrylic partials, okay. Flippers are kind of like a flippy thing, whereas these are acrylic based. They have a reinforcing wire inside of them. They have wrought wire class, and this acrylic allows repair of the prosthesis. So yes, they provide retention and stability. No, they don't provide support off of the teeth. But oftentimes, you don't want to load the teeth with support. You want the prosthesis to be supported by the soft tissue. So you take the stress off the teeth. And these wrought wire clasps, practically impossible to break as compared to a cast clasp. So these make good alternatives, great alternatives for my patients. Allow for disruptions in treatment. It creates stable endpoints. So if the patient had 20 things to do, you could do 5 things and let them rest, do 4 things and let them rest, do 3 things, let them rest, so that they're not continuously coming in, but also, you know, where they stop, they're able to be stable and functional without problems. And no talk would be complete without talking about dental implants. You know, I'm not going to be talking about dental implants, but, you know, that's a treatment option that we have today where you can restore and bicuspidize a person's occlusion so that, you know, they are functional. And finally, you know, this is a case where a patient had 1 tooth and he lost it. So we placed an implant in it. This is one of those old O-ring type implants. I don't use those anymore. I only use locator type implants. And we repaired his existing partial, so he could still wear that, and repaired that tooth area. So remember that the paradigm shift involves putting the patient success at the top, not so much thinking about the procedure-driven activities we do as the success point, but the patient, how successful they're able to, you know, achieve, to be with the things that you do. So think of paradigm shift as kind of like, well, thinking outside of the box. You know, you have your clinical skills, you have the knowledge base, and how can you use these to manage the patient and provide patient and with best possible care, get them more functional, give them acceptable degree of aesthetics within a price range that they can afford. And, you know, thinking outside of the box is more than just going through each procedure. It could be like thinking outside of the can. You know, this is if you're from Hawaii, you kind of get this. We love our spam, and this is how, you know, Thanksgiving turkey in Hawaii could conceptually be. So thinking outside of the can. Okay, so that about does it for me. Thank you so much for sticking in there with me. I know I've beaten you up a bit here, but it's kind of hard to put managing all of these kind of things into a one lecture thing. But I'm hoping that I gave you a feel for the kind of issues that I face on a regular basis and how you too can use these concepts to provide some pretty awesome care for your patients. Okay, so thank you so much. This is my disclaimer. I don't know nothing. I don't do nothing. I just kind of hang out there.
So now we'll move on to the questions.
Okay.
There are a few. Dr. Patel asked, how do you obtain informed consent from patients who are residents of assisted facility who do not seem competent, but there is no family member involved in care and no guardian appointed? Facility states patient is capable of consenting for treatment.
Normally on the face sheet of care facility, there are people listed who have durable power of attorney for healthcare. It's listed on the what's called the face sheet. Face, did I say it right? Face sheet. And those people can be contacted in order to get to discuss the issue with. You know, it's a very kind of gray area in getting consent for patients. Most patients are not conserved because it's a long, arduous process through the court system to determine a patient incompetent and to assign a conservator. Oftentimes it's more of an informal process where you talk to the patient and you go through all those steps, those things that we talked about. And you kind of get a feel for where the patient is and whether they understand the treatment. And then you talk to the family. And they cannot give you consent because the patient obviously is well, they can't necessarily give you consent because the patient is alert, is awake, um, and but they can give you their advice, and oftentimes they will defer to their family member, and then between the two, you kind of come up with a decision as to whether you've given the patient enough information and they kind of understand what you're talking about, and the family understands what is going on, and they understand the costs involved, so that there's no surprises. I think it's so important for us to be transparent with our patients, um, and always include them in the conversation. I remember my grandfather once told me, I'm not deaf. You don't have to talk to them. I understand what you're saying. So, it's important that you include them. But I've always said that, for my patients, they know as much about what's going on in the mouth as I do by the time I finish talking with them. So there's no surprises. Everybody needs to be on the same level, on a level playing field, so that you can feel confident that what you're doing has the patients and the families informed consent and their blessings. So that's how I normally handle it.
Dr. Oler asked, how effective are arch or U-shaped automatic electric toothbrushes, i.e. 360 sonic brush?
If you can get it in the patient's mouth and not have them spit it out before it does the job, fine. It probably works. But like everything else, patient has to be able to accept it in the mouth and position it correctly. Just because the head of the toothbrush is spinning, it doesn't mean that it's doing anything, because if the spinning bristles don't actually touch the tooth surfaces, and I know this sounds stupid, okay, but if the spinning bristles don't actually touch the surfaces they're supposed to clean, the brush is not going to be that effective. And people are so mesmerized with the mechanics of the stuff that they forget that oftentimes it just doesn't work. And I've had patients, older patients, say they don't like these electric brushes because the damn things hurt. They won't tell the dentist that, because the dentist is a big old dentist, telling them what to do and stuff. But they won't use it because it just hurts. It turns too fast. It's too loud. It vibrates the heck out of their ears. It's they'd rather have their plain old brush.
Yeah.
So I've heard about that, yeah, that thing, but I'm not sure if patients are going to be willing to stick all of that in their mouth.
Dr. Letts asked if you could comment on pain medications for elderly patients.
Pain medications, okay. That is a problem with the elderly. I first off, any kind of opioid type of medications or synthetic opioid medications, analgesics, I try to stay away from. Um, the Tylenol codeine is notorious for causing constipation. Constipation leads to confusion and delirium, and that ends up in hospitalization. The narcotics like Vicodin, which doctors used to pass out like candy, not only can be habit forming or addictive, but they can cause some serious delirium in patients, serious confusional states in patients. my cousin had knee surgery, and he said he was taking his Vicodin afterwards, and he saw spiders crawling up the walls and all kind of crazy stuff, you know. So, you know, and he's not that old, you know. So you have to be careful how you use those things. NSAIDs, you have to be careful with also. I know practitioners like to use ibuprofen, but you know, ibuprofen is very acidic, very, very acidic. So, you know, if patient were to use 600 milligrams, 800 milligrams of ibuprofen, it's like pouring acid into the stomach. One of our nurses almost died because she ate a hole through her stomach because she's taking so much ibuprofen. Uh, so you have to be really careful. Oftentimes, you don't need a whole lot of medications for older patients, pain medication for older patients. I think the key is the less you hurt them, the less pain medications you need. So again, it goes back to your skill sets. You know, you know, TLC in providing care, you know, leads to less postoperative problems.
One member asked, I believe he's asking for the initial slide you had up at the beginning.
Okay.
He wants the website that was on that first slide.
Let me go back. Go back. Okay, I'm doing this manually, folks.
That's fine. Someone else, and I'm not sure exactly what they said, thank you for the beautiful presentation, but they also said, what can be done for bitter taste?
Bitter taste. Bitter taste. Like, what do you mean bitter
They
taste?
didn't go into details. That's all they
Oh,
said. They must have asked it at some point during something you were talking about.
bitter taste. You know, I
Maybe.
think the only time I've heard of patients talk about bitter taste is when I squirt the local anesthetic in their mouth, you know, because the needle has gone through the gingiva and now it's just squirting to their mouth. I'm not sure what that
Yeah.
means, so, yeah.
And then the final question I have here is a 91-year-old patient who can't brush well, has periodontitis, mobile bridges, not carious. However, very slow physical mobility for patient with good mental acuity. My plan is to see that the patient every 3 months for pro-feed to prevent any worsening. Keep the teeth as long as possible. Patient doesn't want dentures and asked if implants is possible for her. Patient has a lot of comorbidities. What would you do in this type of case?
I like the idea of seeing the patients every 3 months. If you can get the periodontal status stable, um, you know, then even loose teeth, you know, loose teeth in and of themselves is not necessarily a bad thing. You know, it could be a sign of uh, primary or secondary occlusal trauma. But, you know, loose teeth in and of themselves, not necessarily a bad thing. Loss of periodontal support, again, not necessarily a bad thing, even in the face of mobility. There was a seminal study done by Nyman and Lindy years ago that showed that with aggressive periodontal therapy, full mouth rehabilitations could last years, decades almost. Um, but you know, the key was keeping the periodontal support and foundation clean so that you know, there was no progression or minimal progression of disease. So I like that idea. uh, Implants, you know, basically, I think we're finding now that there might be some age related issues with longevity of implants, but I've always told my patients, you know, implants have a 95 to 97% chance of taking in your mouth, of being osseointegrating in your mouth or succeeding in your mouth. And that leaves like a 3 to 5% chance for it to fail. And you can't even guarantee your tires, for that much. So, if the patient has minimal comorbidities that are related to bone physiology, if they have adequate bone height, if they have good oral hygiene, basically all the things that a younger patient would need to help ensure successful osseointegration. Implants could possibly be an alternative. But I like the idea of trying to maintain existing dentition. I'm not crazy about converting a patient from fixed to removable, because patients oftentimes have very difficult time going from fixed prosthesis to complete dentures or anything like that. It's just, it's a different concept for them.
Okay, the person who asked the other question clarified and said, elderly patients usually take a lot of medications that could cause bitter taste in the mouth. What possibly can be done to reduce the taste?
Okay.
They're grilling you tonight.
I'm grasping. Okay, so this is the first for me, but I can tell you that when patients don't swallow their pills, they oftentimes will report that bitter taste, and I'll find bits and pieces of pills in their mouth. Sometimes it'll be pouched in their cheek. We call it cheek pouching, or bits and pieces of pills stuck in between their teeth. And all these pills are, bitter. So that could be contributing to it. So making sure that, they swallow completely and they don't have stuff left over in the mouth might do the trick.
And I think that is it. So
Okay.
I think Dr. Yang wanted to say something to everyone before we left. I know some people have already left, but not everyone. So here's Dr. Yang.
Thank you, Dr. Kawamura, for your presentation. Very important topic as our populations are moving into this, more and more patients are moving to this sector. So thank you very much. Very, very, very informative. So anyway, I look forward to serving you all in 2021. And please email me. My email address is bexyang@gmail.com. If you have any ideas or suggestions, or you can even contact our dental society and then let us know. We welcome all member feedback, and I hope all have a great evening. Thank you very much. Thank you, Peter.